Okay, why don't we go ahead and get started. Thank you everyone for coming. We usually only have one talk per week, but whenever we have a luminary in town, and that would be our speaker today, not me yesterday, we will move the conference to a different time of the week. So I'm really delighted to introduce Andrei Kushniruk, who is actually not too far away from us, up at the University of Victoria, where he's a professor in the School of Health Information Science. He was previously director of the school and then has gone back to pursuing more purely academic pursuits. And he truly is a world-renowned expert in usability applied to health information systems, and most of his work has focused on that, but I was actually delighted when he told me he's doing some work in whole exome sequencing and usability, which I think brings in, spans the whole program and not just focused on clinical informatics. Just by background, he received bachelor's degrees in biology and psychology from Brock University, master's in computer science from McMaster University, and then a PhD in cognitive psychology from McGill University, and he's been very active in many aspects of informatics in Canada, and like I said, is known around the world. So I will let Andrei present his
Okay,
work.
I'm really happy to be here. It's actually the first time I've been to the department. I've been to Portland once before, but really happy to be here. So my presentation is improving the usability of health information systems from rapid usability testing, and I'll talk about that, to what we're calling clinical simulations. So I'm going to talk about a little bit of history, at least the projects we've worked in, from actually the very first project I worked on to some of the more recent ones, including the one that Bill mentioned that is beginning to bridge into bioinformatics. So we all know the potential of healthcare systems, electronic health record systems, personal health records, decision support tools, educational systems, patient information systems, and mobile and handheld applications. But we also know that there's been a lot of issues with all these areas. And over the past while, we've actually done usability projects on every category here because there was such a demand for some improvements, and we'll talk about that. I always like to just begin where I'm coming from the area of human-computer interaction, and the challenges in healthcare, perhaps the hardest challenges for human-computer interaction than in any other domain, even more so than in any business domain. I've also did a bit of a stint in nuclear power, and even in that area, it wasn't as complex, it seems like, from a human point of view, as what we're looking at. So the point at the bottom is, and we'll look at human-computer interaction taken very broadly. If you take a broad definition of human-computer interaction, it may well be the single most important barrier to successful implementation of systems in healthcare. Talking to Bill this morning about developments around the world, there's a lot of technical developments in some countries that allow people to interconnect patient data nationally. Citizens can access it. But there's a lot of issues around human aspects, and I like to also talk about human aspects as a broad topic, that are preventing that from happening. So from my perspective, the solution was always go outside of health informatics and apply information and ideas from other areas. And the two areas I've sort of come from is human-computer interaction, HCI, and the other one I'll talk a lot about today is usability engineering, approaches to engineering software that sort of came out of the early 1990s in California, Silicon Valley, those areas, and I've been trying to bring them into healthcare ever since and extend the methods. And we'll look at it across the board from system design, not only system design, but system implementation, system customization, training, and even system selection. So whether or not you're designing or building a system or working with a commercial system, it cuts across. So I'll introduce what I call low-cost usability engineering methods that can be applied for developing more usable and useful healthcare systems. Another distinction we like to look at is usable is easy to use, but it's no good unless it's also useful. The content has to be relevant for healthcare professionals. So those are two dimensions. Sometimes the useful part gets lost in some engineering labs. And I want to look at how we measure impact of healthcare IT on work and workflow, because that's also become Another issue over the years, how do we, there's issues with impact on workflow. What are practical ways for looking at that? At least show our perspective is only one. So HCI, or human-computer interaction, involves obviously the study of end users and their interaction with computers. And we'll see, we can look at HCI at multiple levels, from the level of the individual user with the system to the individual user doing a work task, perhaps interviewing a patient, to group or collaborative activities. So we'll also look at individuals and groups, and basically we want to do this to improve systems. And my definition I like of HCI is a very broad one. It fits with a lot of work from Bill and Joan, and that it's that human-computer interaction. HCI is a discipline concerned with design, evaluation, and implementation of interactive computing systems for human use, and with the study of major phenomena surrounding them. So as I can say at the beginning, I said I think it's maybe the single most important factor in health informatics, and that's because I'm taking a very broad perspective, emerging from areas like computer science, psychology, many others. But I'll zero in on what I mostly work in is the area I consider the subfield of HCI, or human factors, usability. And usability, before we used to talk about user-friendliness, and it wasn't really defined well. Usability is a good term because it's had definitions come up. And one of my favorite definitions was actually from 1993 by Priest. And there are a number of dimensions of usability, or ease of use of a system. One is learning. How easy is it to use to learn how to use a system? Learnability. We could spin off another term. Effectiveness. Does the system do what it's supposed to? If you're going to enter medications, does it do it properly? But also efficiency. Does it take 20 steps when it only should take 3? Enjoyability, or lack of. And the reason why I like the Priest definition is because at the beginning she included safety. And safety got lost from the definition. I think if you look up the standard definition now from Standards Organization has, International Standards Organization. I'm not sure if they included it again. But where I'm coming from was this idea of usability engineering as being a set of scientific approaches that can be brought to bear in healthcare. So let's drill down and say, what are the main approaches? And you'll see how we started with these and modified them. Well, the first one is actually a very simple idea, usability testing. It's observing representative users doing representative tasks. We might ask them to do something. I'll give an example of a THINK-ALOUD protocol where we ask them to think aloud using the computer. And we might video record them. So the concept is very simple. If you were developing a lot of consultants in usability, if you're developing a word processing system for secretaries, you'd have secretaries come in, 10 of them, do word processing tasks. In our studies, we'll have 10 or so or 20 physicians come in or nurses come in doing order entry tasks or decision support tasks using a system and video recording. I'll get into how we do that. The next level we'll talk about is called clinical simulations. And this is where we gave a different title to it because it's representative users doing representative tasks. I could have someone sit here and do a usability test, but if I actually have them do it in their real environment, in an operating room or in a hospital ward, we're calling those clinical simulations. And they don't have to be in a simulation lab. And we'll also argue you can do that low cost and high fidelity by taking the study into the organization. And I won't mention much about this one, but this one is also very useful, usability inspection, where you, the analyst, step through and analyze an interface as opposed to watching users. And we've used this on many projects in conjunction with the other two methods. It's a predictive methodology. You always still need to watch the users. So you can ask, when can usability studies take place? When I started, I was at the end of the, and we'll see an example of the very first project. It was too late to help the project. It was after the project was released. We can do studies to test if the system is doing what it's supposed to in the real situation. We can also, I might mention, if I have time, something called the Virtual Usability Lab, where we can track people using systems over the internet. Those are all at the end of the life cycle. Over time, we started moving back, working with different organizations to try to work with usability during implementation. And that's when clinical simulations became very useful because it's near live. And I'll give an example of a near live study just before you go live, catching those last glitches. Moving back into design, you can do usability testing and inspection methods. And even if you go back as far as analysis, I teach in my courses, do early mock-ups of anything you're going to develop and have a think-aloud study of people using them. And even you can go back to planning stages. And I was talking to Bill this morning, even if you're buying a commercial system and you're planning and you're going to buy a commercial system, we're now proposing that most requests for proposals include the requirement that all the candidate systems be installed in the hospital to be tested head-on using usability methods. So if someone asks, when can you use this, it's not just for if you're the designer of a system in a company. It's across the entire spectrum. So that what I call low-cost, rapid usability testing, that it doesn't require an expensive fixed usability lab. There's reasons for using those, but in many cases you don't need it. And the other argument is if you're testing systems, you need to also test them locally. If I have a conformance testing lab or usability lab in Toronto or Chicago and says X product works, and I bring it to my hospital, there's no guarantee it'll work in my hospital with all the interfacing technologies. So what we're saying is we still need centralized testing, but we also need low-cost, efficient ways to ensure systems are safe in our local environment. And when I present this, sometimes people say it's low cost, therefore it's low fidelity, not realistic. My argument's always been if you can test the system in the real environment off hours, and we routinely do this on projects around the world, it's the highest level of fidelity because you don't have to try to recreate the scenario, interfacing technologies, say barcoding. And can be applied, you can either use the laboratory approach, but also we say, we'll see this moving it towards what we call clinical simulations. So what's the equipment? Well, normally I use the cheapest possible equipment, so there's no barrier with any organization. On my computer or a laptop I'm running it, I'll use a free software. I often use something called Hypercam, which just records what you're doing on the computer as a movie file, and if you turn audio on, it records the audio. So right away in Media Player, you can play back. That's my unit of data that I pass around on projects in different countries. They send me that in FedExes. So you can record everything I'm saying or doing on a computer using this recording software. It even allows you, if you're locked down, to run it off a flash drive and store it on the movies on another. And I'll just I put an external camera here to say sometimes you need the external view as well. And normally we never need more than about one. Because if I'm doing a study of how someone's using a system in the office, I may want to know what they're doing on the computer and also if they're using papers or moving anything on the desk. So often 2 views is all that you need. And in some of our studies, we literally had, if it was a simulation study, a camera on a tripod with the Hypercam running on one or more workstations. If it's a live situation, we might have that as ceiling-mounted camera. But that's just me thinking aloud, using the think-aloud method from psychology, while I'm using a personal health record. It's the movie's being stored on here with the audio, and I also have an external view of what I'm doing on the desk. Simplest possible laboratory-style usability test. The data is very clear. You can play it back and see exactly what you're clicking on, which is one of the arguments why you don't necessarily have to have a $1 million lab with the one-way mirrors to watch people using systems. The other sort of framework, and organized the talk around this, as I mentioned, then this sort of triangle, I think we used a triangle because things become less constrained as you go up this ladder. At the bottom, and this sort of came out of work we did in consulting and that as well, is that the simplest way to start looking at a system if there's a problem in an organization is what I call level 1. The system, the user using the system in isolation of anything else. And we can set up a usability test very simply to look at that level. And in some of the studies, I remember one project I did in New York that no one could use the electronic record system. Nobody could tell you why, but when I had them think aloud using it, half the time when the cursor blinked, because I had the movie file, you could see that you could enter data. Half the time you couldn't. So we coded about 200 consistency problems, fixed it. It was easy fix. Not all fixes are easy. Went up to the next level to see how they used it in practice. No problem. That was lucky. But the idea was if you start here, you can start identifying the surface level problems, fix those, and then move up a level. And I'll talk about moving up to the work task level shortly, but I'll just give an example of, and this also mirrors what we did in our studies historically, starting from here, moving up this ladder to more complex situations. But and I'll talk about later how we're packaging it as a multi-layer approach, but in the beginning, we just started working simple studies, somebody sitting down using a system. So the very first one that we published actually was in 1995, and it was for a CD that was going to be given on this little CDI player that would plug in a TV set. I don't know if any remember those. And it was going to be sent to doctors with no instructions. So at McGill, we just set up a room and had 4 physicians try it and 4 medical students. And we video recorded their interactions with the system. Back then, you had to use like a PC to video converter. It's a lot simpler now with digital movie recording. And we had people think aloud and capture the screens. But even then, we were beginning to look at how do you analyze that type of data. So we started using coding schemes. And I will note that you can use computer-supported video coding. Back then, we used a simple program called C-Video, which was a $100 program that ran on a Mac SC that would connect to a VCR, and you could annotate your movie files with it. So we opened up text in that file. There's many tools that are free, Transana, but actually you don't even need to use a tool. You could have one file open on a text file on a computer and watch the video on the other, mark it up. But coding the data was very important. How do we analyze or look at the data? So we brought in the ideas from human-computer interaction for analyzing data. So we developed categories, and again, this was sort of modified from doing video analysis in psychology studies, where you come up with a dictionary, a coding dictionary of things you might look for. This was our very first one, and since we've modified it for many different projects, you have categories like content. Is there an indication that there's too much information, too little? Is the information out of date? Is it not up to relevance? Comprehension. Can the user comprehend graphics or text? Navigation. I'll show you how we use the codings. We still use the same approach. Its ability to move forward or backward. Is the user lost somewhere on a screen? User control. Can they control the pace? System understandability. Can you understand the icons? And even you can code for if the system crashes, which was interesting because in many studies the system crashed and the system log said it didn't crash. But what happened when we watched the interaction was sometimes it didn't buffer returns and it just accidentally exited. So we can also, the coding schemes that we had were open-ended, so why not also look at other aspects, including cognitive aspects, like reasoning? If I'm asking someone to think aloud about a system, they may be thinking aloud, I have a problem with closing the window, but I also think the patient has diabetes. So I'll show how we've used studies where we've also coded for what they're thinking about in terms of hypotheses. In terms of studies that I'll mention where we have had recordings of people using systems while talking to a patient or simulated patient, they're not thinking aloud, so we're recording the interaction. So we can record what requests for information they have of a patient in the interview and relate that to the computer screen. And I'll show you an example of how you can look at how the screen changes the interview. You can also do things like, of course, analyze mouse clicks and things. Often we don't go to that level. But this was our log file. This corresponded to the video of that very first user that we had. And it was for, when it was done was we did the study in 1992. And you'll see that they're mentioning, as you're reading this, that they think the information's too old. It was set on, it was 1988. Apparently all the guidelines had changed in 1990. So everyone was sensitive to that. At first, the user says, I've had to loosen my tie. If I had the video, it's quite funny. And you can click on the number. It goes right to the part where he's just sitting here. I'm recording him. And says, my first comment is 88 is old. I don't know if anything has been updated. So we're very interested, again, not just usability, but usefulness. This was a usefulness category. You can watch as the user goes through the different parts of the system. It had a decision support component. Clicks on different cholesterol levels. And then gets stuck on the video. I have it if anyone wants to see after I digitized it. How do I fast forward? So that's an example of a navigation problem. That comes from our dictionary where we define navigation problem, and we can even do things like inter-rater reliability and have 2 coders do it and come up with a kappa coefficient. We only do that if we're publishing usually. But this is nice because we can code for different issues that are usability issues. So we can say, for example, 80% of the users that used Module 1 of this EHR had an average of so many navigation problems. It focuses you, and when you take it back to the developers, you can go right to the video section and show them where this occurs. There's no way out of this, and then the system actually crashed. This was a system that was going to be released widely, so that's after that project we decided to always work earlier in the design cycle because it was too late. And then things have changed a lot. I'd probably turn it off. And then he can't find the options menu on the help bar. It didn't come with instructions, literally didn't. It was supposed to be easy to use. And now he facetiously says, I have to get out the owner's manual. So, I mean, this was 1992, but unfortunately, we watch users using healthcare information systems today, and I've seen lots of examples that are still in league with this one in terms of issues. And at the time, we were also interested in what the normal way of people were assessing usability. And, you know, I was talking to Bill. A lot of times people say they're doing usability, but maybe they had a focus group or they gave out a questionnaire. And questionnaires are useful. We use them a lot on wide-scale studies to thousands of users. But for these small-scale detail studies, this was what that user actually said. I found the program easy to use. And there's a 5 or 7 point scale. We just put the answers. He agreed somewhat, fairly easy to learn, agreed somewhat. Content of the program is presented clearly. Well, agreed completely, but we never thought to ask, was the content out of date? So it was an emergent issue and an inadvertent consequence of the system that you needed the video to watch. So what we tended to do is after we have someone do a task, just keep the audio recording on and have a semi-structured interview. We ask them, did you just have problems now using the system? And when you do that, you end up having something that corroborates your video usually or enhances it. And in studies where you can't actually have somebody thinking aloud, like you're looking at someone doing an operation, you're looking at the operating room system, then you can do, Elizabeth's done this as well, post-cued recall where you play the video back to them and you record the interaction. So that was our very first study, and then we got interested in cognitive aspects of usability. What was the impact of systems on reasoning, individual decision-making, group decision-making, and technology-induced errors, inadvertent introduction of errors? And we wanted to look at how that could be integrated into usability. So many of the other studies are pure usability we've done, but many are also dealing with, also looking at the impact of usability on work performance and decision-making. So that's, I just put in this organizer level 2, the user interacting with the system and their environment to carry out a work task. And our first experiments in that was looking at the user using the computer system interviewing a patient. So now we've moved from the individual situation to more like a distributed cognition situation. And this is where we started using the term simulation, clinical simulation, for analyzing impact on workflow. And I'll show different type of analysis. That was a series of papers that were actually done at McGill. The first one we had was from MD Computing in '96, and then there was a JMIA paper in 2001, where we had a whole clinic that was going from paper records to electronic. We actually had some going back to paper just to see what would happen. And we were looking at matched records for learning styles and direct observation of the process of them learning how to use and adopt the system. So in one of the cases, we had the classic level 1 THINK-ALOUD, where we had them think aloud using the system. And this was interesting because then we said the company that had made the product wanted to know how the system was used when the patient was there. And no one had looked at this, so we borrowed from the, and I guess you have that here, the simulated patient, standardized patient paradigm, just put the computer in the middle. So what we're recording now is the computer screens and the dialogue. So it becomes a different type of dialogue analysis. And we also had set up so that we watched the progression from a person interviewing a standardized patient with no computer, and then the introduction of the computer and over time to see how they adapted. And you could see definite styles. And we also won't get into, looked at people entering on paper, asking to put in the computer exactly and vice versa. So that was the system, and it was an interesting idea at the time. It was something called the paper scroll metaphor. You'd scroll along here, and you'd click on categories here. So if someone came in with a cough, you'd load a cough template. And then what happened with this system, and just jumping ahead, is that it had an impact because there wasn't really an easy way to search the page for where you wanted to go in your own head. So if you logged in early to a template, there was no global search. And so people would just start asking questions in the order on the screen or say, I'm not going to use the system at all. So on the video was the first thing we were watching late at night, the videos, and we see people that walked away from it got bogged down on the screen, and other people said, I get the idea now, and just started asking, filling out on this order. So it wasn't to say all systems did that, but it was to say that systems could have a profound impact on the interview. The other part that was interesting was when we did the experiment where we asked them to enter their cases in here and also on paper, and also counterbalanced it, that there was about 25% less information in here, and there was a different emphasis of information. And when we looked at information items, and the reason is that some of these categories on the computer screen were more or less developed. So if you had more subcategories under this tab, more information would be presented or less. So it was, again, another example of how the system, even what information is on the screen, might impact what's recorded in the system. This just summarizes. We interviewed 16 clinical staff, did usability testing. This was our first time. We also looked at training. I mentioned to Bill on some of our projects, what we've been doing is going in and looking at the training. We did this on a rollout of a system in New York, looked at the actual training for the vendor system to find out what they were taught, and then did usability tests 2 months later to kind of get a learning curve on it. And when something was missing, we could go back to the training and see whether there was an important piece there. With this particular system, the most predictive thing of adoption was actually, did they get far enough in the training to learn how to recustomize the interface? But most of them had dropped out before then. So it was really interesting because you could log all the system use over time, and they didn't have to adopt the system. So it was one of those studies where you could say we're looking at people's real choice of adopting or not. And I just mentioned that already. For corresponding records, they generally contain less information items and change in reasoning. So we said before, when they were interviewing the patients, they were hypothesis-driven. The standardized patients, they were going where they wanted in their own knowledge base, whereas with this system, they tended to drop into screen-driven behavior. And that we were relating at the time to medical reasoning, saying that the more expert-like reasoning is from pieces of patient data generating multiple hypotheses we call forward-driven. And less expert, or when you're learning, is more backward-driven. You have a diagnostic hypothesis looking backwards to the conditions. So it was interesting that in some cases it seemed that the system, until they adapted to it, brought some expert physicians more down to this level, and then they learned how to adapt to it, or it didn't adopt it. And the way the actual, and you'll see how this related to later work, the granularity of the coding is different. Now we're not looking at this is a log file, the individual thinking aloud, but on the video we mark it up, and first 2 minutes they go in, create a patient visit when they're interviewing the patient. Gather information. This was an experienced user, was going to start to use the system after 3 minutes, but then decides to continue writing on paper. Eventually, after 9 minutes, chooses a clinical template, goes into the system, and follows the screens. So when we interviewed him, he said he realized, this was after 6 months of use, how the system was useful in guiding you, but you needed to not be triggered too early to go into the system. So that's where we got there. Now what we've gotten to more recently is level 3, looking at moving it into more and more real situations and having studies that actually take advantage of the different levels. And just before I get into there, we can say just on a continuum of studies, if I have someone in a laboratory or sitting down here doing artificial tasks like entering from paper into an EHR, which is a good task for picking up surface problems, we call that laboratory style. That would include the THINK-ALOUD method. The simulations that I talked about are simulated doctor-patient interviews, or clinical simulations are kind of in the middle. They simulate workflow. And then you can also go into the naturalistic setting and the real setting and also run simulations there. We call those, I don't have it in there, in situ simulations. But you can also study the real thing. So in many of our projects, we set the recording equipment up in the location. And assuming they have IRB approval, we can do a prediction on a simulation and then see what happens when the recording goes live. So level 3 for error identification, prediction, and mitigation, it's another check before systems released widely. As I mentioned, before system is released across a hospital, say, what's the impact on workflow? So our argument was just extending the approaches, need for low-cost portable approaches for conducting simulations in emergency rooms, ICUs, or hospital wards. So this is an example. This was a recent study, 2012, that we did with, it was with Mount Sinai. It was Joseph Canry and Tom McGinn and Devin Mann. I don't know if you know them. It was an International Journal of Medical Informatics. It's a series of studies that included all 3 levels. So we kind of moved to packaging it this way. The study employed several phases. We had a level 1 where we had a bit about the tool. It was called ICPR Decision Support Tool. It was a evidence-based guidelines to be incorporated into a major vendor product in the hospital. And we were looking at how to increase the actual adoption of guidelines at the end of the day. There was actually a clinical controlled trial. But we wanted to see how usability could be applied. So we said, let's look at this from multiple levels. We'll do a level 1 analysis, a surface level usability testing. 8 clinicians came in, And we kind of drove them through the system. So they were forced to go through different parts of the system. So it wasn't exactly a think-aloud. It was like, here's a scenario. Now what would you click on the screen? And think aloud. The second was a clinical simulation where we didn't have a human patient. We wanted to see how the guidelines would be triggered in their workflow, so we had a digital patient on the computer screen. So they could ask for information in the order they wanted. The first one forced them through a certain way. And the third one was we did some limited studies of recording live interactions with the use of the guidelines. This was a bit trickier because how do you get the thing to trigger just for those cases where the guidelines are needed in the real situation? It was an experiment. We were doing all three, but the first two definitely were more successful. The first one, I can just say some examples, and you'll see in a minute. The first thing that came up when we did the testing was one of the screens should have triggered the guideline, and a window came up with an acronym BPA on it. And does everybody know what BPA is? Yes, the best practice. Well, where we were testing it, nobody knew what it was, so no one clicked on it. So on the surface level usability test, it was a little bit more interaction than that. We'd say, why didn't you click on it? They'd say, well, I don't know what it is. Why would I click on it? So it wasn't very obvious. I think we had them put some written out text or make it more clear. That was a surface level issue that would have prevented people from using it. So we check-marked a lot of issues like that and then went to the second level. The second level was when they're interviewing the digital patient. And you find things like it didn't trigger when we thought it would, or in cases we'll show you how we analyze triggering, how it triggered too early or too late. In the scenarios, if somebody had put in a medical assistant possible pneumonia, in some cases it was triggering off the keyword and immediately coming up with the risk calculator and could move you into something called the smart set very quickly. So it was too early triggering. In other cases, people said it didn't trigger or triggered too late in the process. So there were a lot of sensitivities in doing this. So as I mentioned, each phase identified different problems, the BPA labeling issue, level 1, early, late triggering. So the idea was there was the prototype. Prototype went to level 1 usability testing with 8 users in an office, didn't require a lab. Redesigned fixes were done. The level 2 simulation was done, and that focused more on the actual triggering and the workflow of the guidelines. Redesigned fixes were done, and then it went to a limited live study and a randomized control. And they were amazed. I don't have the stats there, but the uptake of the guidelines was much higher than they usually were because we'd done this preparatory process, which normally isn't done. That's the alert. This was for clinical prediction rule about strep came up. So a bit small there, but at least it's written out there. If they wanted to see more, it went into the second component, which was a calculator, risk calculator. It's interesting because when we did the analysis, we found people really liked the calculator. Some people were even going in the system just to get the calculator function because they wanted to check their decision against the latest guidelines. And so if you fill this calculator out, you get a strep score. In this case, we did strep and pneumonia. This one said the scores between 1 to 0. If it was a high risk, then you would also be asked, do you want to go into, moves you along to the next level, which was the ordering set. So this is a good idea in that, but it was we found a lot of issues that if we could tweak it, we could get the adoption better. Oh, this was how we coded usability problems, some examples. Usability, here was an example. It's becoming a lot of clicking and reading, and you want to do this thing quickly, especially if you have a lot of patience. Visibility, that was the code for the issue that I just mentioned. I just see the BPA alert here. Normally, I probably wouldn't see it since I don't usually look here. This one knew what it was, but said it wasn't very prominent. Workflow issues. I think it depends on when you start using the tool, because if you use it right from the beginning, you can get distracted, forget to go through questions maybe. Content, that was an issue about, I think, some recommendation about giving soup. Someone had some issue with. And then usefulness. I don't like this. It was the order set part as much. I realize this is all about evidence-based medicine, but I just think there's more in a clinical practice, and this thing is pushing in a direction without taking account the full clinical picture. So in some cases it was because it triggered too early, and they were saying, I haven't even asked for an X-ray, and it's pushing me in this direction. So again, the sort of sensitivities of how to integrate. We looked at positive and negative statements, both in terms of coding categories, content, navigation, readability, understandability. Usability was mixed. Half the comments were positive, half negative. But you expect on a usability test to get some negative comments. We also looked at the different components of this system, if you will: alerts, calculator, smart set, documentation, patient instructions. And what was interesting, as I mentioned, it was our perception when we watched them, and we also coded whenever they made a comment, that they did almost all the comments about the calculator were extremely positive. So you can use this approach to take apart a tool that some people may like and other people may complain about, to kind of get at how to optimize it and what do people actually like in the functions. This was just an example of, we went into looking at the triggering rates, how often were the guidelines triggered, and how often were they triggered and then responded to. And this was just looking at how we analyze workflow components. We said, for example, if they were doing on the screen doing diagnosis and orders, that's time spent in the order diagnosis and order field. ICPR CDS was time spent using one of the CDS components: alert, calculator, smart set. The time spent doing that. Time and progress notes, and our RVF was time and reason for visit. So I'll just show an example what you can do to analyze this. We wanted to come up with a way to analyze different sequences. So this on this column is just saying the first, second, third, fourth, fifth thing sequence component access. And then we were able to characterize some different styles. This was called early reason for visit access. This was late reason for visit. The reason for visit usually triggered the guideline. That's why we were looking at it. We were also looking at cases where the guideline didn't get triggered. So just to give you an idea of how we could look at the order, so we did a pie chart looking at different time using the system. And we could also relate that to the comments about what people liked or didn't like in terms of the guideline. So I've already mentioned in phase one, the results were identification of usability problems, main problems to do with usability, visibility of systems status or visibility of a guideline on a screen is an important category. Workflow, I've mentioned the issue of workflow, content navigation. And as I've mentioned in phases 2 and 3, there were different workflows that emerged, including early and late triggering of the rules. And we also looked at that in the near live situation. So adjustments were made in all these. That was one example of one that had all 3 levels, where we found that one level wasn't good enough to catch everything. A second example I have is of another recent one. I did this with a colleague who's doing his PhD from Denmark, Rasmussen. And we were looking at a bit of an experiment of, is it useful to record hours of video, so digital video, of people using a system, and how can you analyze that? So the project was one in Denmark where 3 hospitals were implementing electronic whiteboard, and we installed the same screen recording software on all the machines, HyperCam, at 3 locations, and there was about 166 hours of data. And we created log files that had a lot of entries, 2,863 entries. And it was for his PhD, so he spent a lot of time sitting down just analyzing it. But he only had to do it once, and he was basically analyzing it almost in real time. But even given that, we found that once it was analyzed, we could then search the file and look up any type of situation, error, or problem. It was only one time you had to do that. And these systems were already being put in use. So there were many system-related usability problems that we were looking at, ones that reduced over time, and other ones didn't change over time, and some even seemed to get worse over time. The organization didn't seem to adapt. Although we didn't control for who came into the emergency departments, they might be new people coming in. That was the electronic whiteboard screen, typical electronic whiteboard screen, but we had hours of continuous running data on the live situation. I'll just show some examples. So even though this wasn't a THINK-ALOUD study, you're able to go through, and a lot of it is blank space. No one's actually using the computer. So after, that was my point about how it didn't take so long to analyze later, because the first pass, you've got to watch, wait, and then you mark when something happens. Someone came on and typed something in. Here's an example of an efficiency problem. The user enters information in both the free text field and search field when it only would it be necessary to enter information in the text field. So we were looking at even things like that, but there were also, amazingly enough, system bugs. When entering free text information in the next stop dialog box, the system deletes all information for the current patient. And we saw that, and we were looking it over. We kept replaying it, and it kept happening. And no one had commented on it. The thing had been in use for months across 3 hospitals, so it was kind of scary. Work patterns, just an example. User opens the location field, selects the Team 1 tab, selects an option, clicks OK. It removes the patient from the current view of the whiteboard. There was some issue with lack of visibility. We also were looking at number of steps. Rasmus also did a paper using something called the GOMS model, where he was looking at how to optimize the number of steps. And that all went back to the developers because he actually ended up working for that company. So one of the ideas is combining the approaches, and this is where we work with Elizabeth, and how does usability relate to safety? And safety is important, and we can do error reporting systems, but we've been focusing a lot on trying to be proactive. What can you do before you release a system to try to reduce errors? So it's the MEI Yearbook of Medical Informatics. We kind of packaged what I just said in this lecture as perhaps we need to have multi-phase evaluations prior to release, starting with a prerequisite laboratory level 1 testing, moving to a clinical simulation, and then in situ or near live testing before releasing systems. And I think that paper that we did with Ellis Lee and Henry illustrated that with the guidelines, because we packaged them all together in one with better outcomes than we would have just doing one. This other question comes up. Are such approaches really low cost? If you know the usability area, they'll often say that the usability inspection is low cost. That's the one where you don't watch users because you're an analyst. You just pay one person to go through it. But no one had really done anything on, is the video analysis easy to do or cheap? And so we just did a little experiment on that. We've done a few others on this. The objective to determine the cost effectiveness of what we call low-cost in situ clinical simulations. So this was a master's thesis. We had him collect up all the costs of doing it. He was a consultant on a real project, applied the low-cost approach for a disease management application using only 2 case scenarios. You'll get more cost benefit if you can do exhaustive testing of all kinds of cases, but this was only going to be done in a few weeks, so we only had 2 case scenarios of physicians entering data. Collect all the data, analysis costs, quantify benefits, and calculate a cost-benefit ratio. So this was actually the disease management system tested, which actually didn't end up being used in BC, but it ended up in the Yukon. So he was developing the system, and also that was part of his thesis. So he had people come in, 8 users, listed them for what they'd actually cost for their time, and calculated the whole thing. And then there were fixes that had to be made because they were actually going to release it for real, and he had a table of charts of what each fix would cost. So the total cost of conducting and analyzing the data, and the only reason this was as high as $8,000 is because we included the one-time cost of the laptop. But if you take that out, the benefits go up. Rapid analysis, only looking at 2 scenarios. We could have looked at 20 and increased the cost-benefit. Detected a range of problems, both usability and safety issues. And I mentioned this came up more than one system we looked at, unfortunately, was that they found that it was going to be released, and this testing wouldn't have normally been done, but the body mass index calculator didn't calculate properly. So when he defended his thesis, remember the externalist from computer sciences said, but that's not a usability problem, and it would have been caught. And he said, no, that's not a usability problem, but it wouldn't have been caught because we were planning to release it. So as another layer, a usability test or clinical simulation isn't just for usability or clinical workflow. You'll catch other things that weren't caught before. And safety issues were identified by the medical expert, potential costs of going undetected. Well, that's harder to estimate that one. But the most conservative he had for the things that he would have to fix because it was going to be released and come back, but he caught them, was that at least would have saved $15,000, at least the most conservative. It was much higher if we had spent more time collecting data. And we had no way to actually estimate cost of an error, so we just looked at what was the U.S. litigation cost for a major adverse event once. And I don't know if that's correct, but it was a lot of money, right? So he said if it had prevented one case that was serious, say the body mass indicator was the wrong dosage calculation, could kill somebody, then that was worth that much. So there we go. Advantages of in situ testing, this approach of taking it to the real place. You take into account the context of the system use, the environmental context. We did another project in Japan where they were bringing, it was 2006, and they were moving in a hospital to barcoding with medication administration. I think Elizabeth might have mentioned this one. And when you were looking at that study, if you tested the system in isolation, you wouldn't know how it interfaced with the barcoding. So again, the argument that if you want to, and they called us in because they we knew the CIO, and they said, we want to make sure it's going to be safe when we release it. So they wanted just another check to do it, and again, it was low cost, so they let us do it. Geographical context of use rather than a central usability lab. If BPA is a term used in one state, but you're in another state, no one knows what the term means, that's an issue. And it gets even worse for us because we're in Canada and we're often buying systems that come from the U.S., so a lot of it is really problematic, the cultural issues in terms. Fidelity of testing, as I mentioned, can be higher, it can be cheaper to conduct, and can be an adjunct to centralized testing. Some recent projects I'll just end with. That approach was applied to telehealth. Again, one of our, we have students in our program that are out there doing things. He was the director of the BC HealthLink, which is the 911 calls to nurses that have decision support systems at the other end. They get thousands of calls per month. He applied some of the methods, including not just the usability testing, but the inspection method, where you analyze as an analyst the interface. So he actually counted things like he came up with his own metric, screen turning. How often do you have to change screens and doing while they're going through the workflow, talking to a patient on the phone? And they were able to reduce, and this might sound like much, the call lengths by 30 seconds, but there's thousands of calls. And they also decreased the amount of griping of people that were using the system. So that was it was sort of a cost benefit, not in terms of dollars, but FTEs. The other one, we've done the usability approach. We were doing a project, Elizabeth Bricky and some others, colleagues, on electronic MEDREC planning kit. So we really tried to push into there that if you're going to electronic medication reconciliation, that the proper analysis of the usability and clinical simulations be included in it. I think also you did a national one for barcoding and pushed the same idea. And just one mention of my first venture into anything bioinformatics related, did usability of a clinical exome analysis software. And we're also interested, talking to Bill, in looking at integration of genomic data in clinical practice from a human factors point of view. We haven't got to that part, but we have done some comparisons. This was the study in Journal of Biomedical Informatics. We had surveys, interviews, and THINK-ALOUD protocol analysis with the screen recording of 2 exome sequence analysis software packages. Subjects were 10 clinical geneticists. All the user screen actions were recorded, just like I've showed you. And because there were 2 systems, we were also able to counterbalance and at the end ask them which system they liked and why and what features. The idea of this was also to come up with recommendations for design of new tools based on analyzing existing tools. And so what we did was have one system that was actually a graphical user interface tool, and the other one was a command line-based tool. So we're looking at some of the issues. Results, there were 193 usability issues detected in using the tools. And the majority concerned the layout and navigation and interoperability. Pipelines of data going in and out was an issue. And data standards to do with this type of analysis. So implications for design, they wanted richer filter functionalities desired when they were doing this analysis, like looking for mutant sequences. The scenarios were actually looking for trying to detect mutant sequences. Faster response time needed on one of the tools. Both tools elicited the idea of comments about team support to allow multiple clinicians to annotate or review the data. And they also wanted more frequent updates to support new input types and tools. I don't know if you're familiar with either of these. The first one was Varsipter. This is anyone familiar with these? No, this is a graphical interface tool. On the left side here is the view of the variations, and there's these pre-built filters, and this is on the right side, the graphical feature for a user to custom design their own queries. And it was interesting, we were looking for implications, so we also looked at one that was apparently used, KGG sequence. It's a command line-based system, and we were, same idea, we had them go through. And we also looked at how, using both tools, which was more successful for finding the answer to the case while they were thinking aloud. I think this one was, but it was frustrating for other reasons. Being a graphical interface, it tended to be slower sometimes, and sometimes certain screens were covered over other screens. So it was the same idea. We just started applying this to look at, and that paper actually comes up with some recommendations for design of new tools. So I just thought I'd mention that there's some bioinformatics. So we have worked on bioinformatics just starting. We'd really like to look at human factors issues in bioinformatics areas. So if there are any possible collaborations there, I think that's a good one. Other applications, as I mentioned, things like mobile apps. We're moving to doing some projects. We have a Center for Aging at the University of Victoria on applications for the elderly. And as I said, we continue working on electronic health records, decision support, and other types of applications. This was actually a screen from a system called PATSYS that we used the approach on back in the late 1990s. That was the first web-based access by patients to their own records over the web. And now there's all kinds of access, MyChart and Epic and Veterans Affairs, My Healthy Vet. So it's changed a lot since then. So our work since 2000, as I said, is trying to move to predictive analysis to prevent errors and improve usability. A range of testing methods. Saw a number of papers, if anyone's interested. We looked at improvement of software, improvement of the process of development, and the process of integration of technology. This was interesting. Again, as I mentioned, a lot of people will say, what can I do? I have a vendor product. But there's a lot that can be done if you track along the users in terms of customization or feedback. If there's an issue with the commercial system down the road, we often say, what can we triage that and say, is there feedback into the system development team for customization potentially, or perhaps there's feedback to training, or perhaps the issue is so serious it has to go back to the vendor, which gets to the new approaches for software testing. And last but not least is the whole idea of procurement. If we have so many problems with systems in the first place, can we not have more rigorous analysis of systems before they're selected? And what we proposed, and this has been done in a few places now, is that the procurements involved in the RFPs test installs of systems in representative hospitals with usability type analysis. And in that case, usability isn't just for usability. If you do usability testing, you'll also determine functionality. So in one case, there's a hospital in France that did this, and we had it in our paper as a case study. They required all new systems to be test installed and accessed by real clinicians, and they could compare them. And they found one product was actually from Germany, and it wasn't completely translated. So they picked the product from France. They actually took the report, the usability report, gave it back to the vendor. There was a cycle there where they could actually make changes. And then they improved the product, and the product became widely used in France. So it was a real success story of doing the testing in the procurement. So conclusions: to ensure system usability, the idea is we think there's a need to disseminate these methods, to demystify them and say it's not rocket science and it shouldn't just be done in a centralized lab. And laboratory-based simulations are obviously not enough. When you get systems that were laboratory-based somewhere, in Wisconsin or Kansas City, wherever, and you're using them in your real location and you're having problems with them, then you really need a combination both of centralized testing and localized testing. And this is where we think the methods come in. This idea of layers of usability testing and clinical simulation before release, if we want to make sure systems are safe. And my last point is, we teach this routinely. I was talking to Joan this morning in our courses. Within a few weeks, we can have students doing assignments on systems they're using or other systems, and they'll be doing consultant-level reports using 2 or 3 of those methods. Usability inspection, I usually start them with, and simple usability testing. And many of them have found really interesting things about systems that they've been using for years that needed serious adjustments once they started doing the projects. Okay, that's it. Yeah.
So I'm just going to remind people who ask questions to hold down the button so people can hear it, and then let me also remind anyone who's listening out there in cyberspace that if you tweet with hashtag #DMiceConf, you'll be able to ask a question as well. Very nice talk. It's always good to get an update of what you guys are doing. I particularly like the approach because we use so much commercial software now. There's very little software that gets developed, at least de novo, in academic informatics settings. How have the vendors responded? Because there's a I'm trying to think of the right word, kind of the rumor on the street, that most vendors are somewhat antagonistic to, people telling them that there's usability problems with their software, even though they may have their own usability labs. In fact, what they've asked. But how have the vendors responded to these sorts of approaches?
Well, I had started working with vendors, but then whenever we had changes, like one of those systems needed a map, it was released 2, they never would change it. So I've maybe ended up working with regional health authorities and public sector that's buying systems, but still trying to work with vendors. I think, and that's sort of why in this presentation I kind of mentioned the need for local testing, because I think there's been a bit of a communication gap. When we've talked to some vendors, they've said, we know all about this and we do it. We do it routinely at the beta test hospital in some city. And then when you look at it, it's puzzling, because you go, I've received this system, I'm in another city, and it's not even in the same country, and it's not working properly or not working to fit our workflow. So that's where we sort of want to push the theme of the vendors should do as rigorous testing as they can, but it's also going to be the responsibility of local sites, because the vendors won't be doing that, to do their testing to feed back to them. But we found a bit of maybe a miscommunication with some vendor organizations that have felt that this is being taken care of, and then you get the discrepancy from the end users. And I will note, even in countries with a colleague of mine has done, she does questionnaires to 4,000, all the physicians in Finland, and they're 100% use of EMRs. They have to use them. But her questionnaire is about usability. Johanna Capio. And there's a lot of dissatisfaction with the systems out there. And they actually noted on the questionnaire they would like to be more involved by providing feedback to the vendors, but they don't feel they're in the loop. In Ontario, Canada, there's a program that lets you pay, that government pays for systems you buy. They have started creating sites like Rate My EMR, like Rate My Professor. So that's kind of also another move towards that. And I've heard in the United States there would be more sharing of information about vendor products. But it has been an issue to get back to working with vendors. So I think I've personally been working a lot with organizations that are hospitals. They're on the line. They want to make sure it's safe, or it's a region, it's a public region, and they want to spend money to buy a system, make sure they get the right system. So yeah, long answer, that's a real issue. I think it's a knowledge translation and communication issue. Yeah.
Thank you for the talk. What would you say to our human factors colleagues from engineering backgrounds who keep asking, why is this so hard?
Well, it's they're probably used to working in other areas. I mean, you could compare. They've done very well in aerospace, but there's a whole mechanisms there and processes. A lot of the, I also teach systems analysis and design, and I taught it generally, but I'm trying to adapt it to healthcare. And a lot of the methods and processes for developing systems are using approaches that would be used for business applications in healthcare, which is a safety critical area. So it's sort of a mismatch in the design of the systems. And not as a dig to engineers, but I've often seen engineering labs do these type of studies, and they focused on the optimal screen layout, which is why in the first example I gave, it was also about usefulness. So they may be more worried in other areas about how to optimally lay the information out, whereas this one's got the clinical content. Is it of value? The subtleties of how even organizing the information might change how you ask questions, which therefore changes your direction of reasoning. It's just so much harder than any other area. Yes?
I was intrigued by the conclusion that you made that users' perceptions don't always agree with the actions captured in video. And do you have any recommendations for reconciling the two sources of data, and where does the truth lie?
Yeah, that's a good question. And I think one of the issues is time lag. People forget things, although those questionnaires were given after. With that example, I'd say one of the problems was why you need to look for emergent impact of systems is because on a questionnaire we presuppose what we're looking for. Something new came up called screen-driven behavior we didn't think about. So that's an issue of what was the question again?
How do you reconcile video data compared to questionnaire data, and especially when they don't agree?
Yes, when we didn't do questionnaires and we just had an interview going, it was actually quite close because we usually just use five or six prompts, like you just did the task. Tell me, did you have any problems? And we match them. The questionnaires, again, because they have presupposed categories, they're not free-flowing. And even when you have a text box for them to enter something, they may not enter it. Or in some cases, I've had them filling out very good and then handing it to me. I want to encourage you, thinking I'm the developer. So we get more from a semi-structured interview probing what they're doing. And regarding that, another interesting comparison is that as doing those interviews right after doing a series of tasks versus a focus group. An issue with focus groups, and they're often very useful, and we still do them, is that the focus group, the use of the system and the focus group might be some difference in time elapsing. So in some of the studies we did where the users were able to tell us right after using a medication administration system, this won't work during an emergency, that discussion wouldn't come up in a focus group. So in focus groups, we've tended to also bring in the artifacts and have them work through it. So it's more immediate rather than trying to recall what you did a long time ago. Yeah. Well, it's self-report, and if it's about the experience, about the usability, what we found, like that kind of, I'm going through navigation problem, questionnaires were not so useful for that, although sometimes they have been useful. There was one example on a large project in Canada. It was the Canadian Defence. They sent out questionnaires to everybody, and everyone came back. The system was too slow on the questionnaire. But then they went to the company that developed the system, and the company said, oh, it must be your international network. So then we did a qualitative study and found out why it was too slow, what part of the system. So sometimes the questionnaires can trigger something, and we often use them. The other way we use questionnaires, I didn't get into, something we call the VU lab or virtual usability lab, where we track people using systems live for using guidelines and things, and or a new system over time. And a questionnaire that we found useful was saying that every few months we had a questionnaire, how's your relation with your provider going on a 1 to 5 scale. That was a really useful use of a questionnaire item, and we could disperse it to thousands of people. However, for the kind of studies we were doing where we wanted to know what to change in the user interface, a questionnaire often, even if they wrote something was highly unusable, it doesn't give you where or what to change. It could, yeah. Yeah. Yeah, and then that would warrant further investigation. Yeah. Yeah, and the other one, as I mentioned, the studies, and this is we did a paper in this last year's medical yearbook of medical informatics, because the theme was on big data. So we're going, what's big data related to this? There are some large-scale usability studies that are questionnaire-based. So the one in Finland, what she did was send a very nice questionnaire out to every physician in Finland. She even had them compare the government-recommended products, and that provided a lot of really useful information. But now that group is actually going back and looking at some of the usability issues. So exactly like you said, it was a triggering. Or the example I gave of everyone in the Defense Department in Canada saying, this system is too slow. But then without further investigation, there was no conclusion, no rectification. Yeah. Yes?
It may be an issue of asking the right question, because you ask the question, is this system usable? People say, yes, it's very usable. But, the fundamental question, would you ever use this in clinical practice? And the answer may be, no, I'd never use it because I never see this kind of patient, or I never deal with this problem in this way. So it may be an issue.
The type of the way the question is framed, yeah. Because they could say, maybe I'm answering it, is it usable in this session? As in the case of the one I gave where they said they could do the task, but when they're with the patient during an interview, they said, I have problems with it. Yeah, yeah, exactly. Yeah. context. Yeah. Yeah. Okay, thanks.